Apologies for the shirt. I'm in surgery this afternoon, and me and my GP colleague have dress down Friday competitions each Friday, and today is Wear the Loudest Shirt Day. So I texted him this morning and said it's pink for me today, and he said pink's not a colour, it's an attitude. So I'm looking forward to seeing what he's going to turn off. He'll have tassels or something like that. My name's Paul Bowen. I'm a GP up the road at Poynton, a GP partner there. I'm also a GP chair of the Eastern Cheshire CCG. I suppose from a point of view of today, I'm also a local resident. I live up the road in Wilmslow with my family, and I'm a patient, and I kind of hopefully represent many aspects of where technology is impacting on our life. I want to talk about how grateful I am to have the opportunity to learn from you today. The NHS has traditionally been a little bit, well, not a little bit, a lot averse to adopting technology. As Alison said, show me the evidence. It's easy to do that with a drug, but technology requires a very different approach. And the NHS has traditionally, in my experience, sort of been resistant to adopting technology. And I don't think that's the technology's fault, that's the NHS's fault. And what I want to share with you today is my observations as being the chair of the CCG over the last 5 years, and understanding where I think the NHS has to change fundamentally in its attitude and its behaviours in order to properly and effectively adopt technology at every stage. And I hope to learn from you where you feel those barriers are in the NHS, where you feel that we can remove those barriers, particularly here in Eastern Cheshire. And I'd like to talk to you a little bit today about how Caring Together is prepared to rip down those barriers to allow technology at every level to start to be adopted by our system. I'll start with this. Does anyone recognise this? Anyone have used one of these? I don't know if anyone knows what that is. It's, I'm looking for Dr. Way, one of my colleagues, my diabetes colleagues. It's a 1970s glucometer. It's one of the first available blood sugar testing kits. It's plugged in and had a little dial on it which showed you your blood sugar. And this resonated with me when I saw it. And there is a bit of a running theme about diabetes today. I'll make no apologies for that. Back around 12, 13 years ago, as a relatively newly qualified GP, I went to a wedding. I was also training for a triathlon at that time, and I was congratulating myself. I was losing weight, and the weight was dropping off me. It was incredible. But I wasn't feeling any better for it. I was feeling increasingly tired. I was very thirsty as well, but I was drinking a lot of beer at the wedding, and I put that to that side. And my friends were saying, "Gosh, you've lost weight." I said, "Yeah, I've lost weight," and I kept on going to the loo. And to my shame, it was actually a colleague of mine who wasn't a GP. He was a radiologist, and he'll remind me of this to the day I die, that he said, "You're not diabetic, are you?" I said, "No, I haven't been diabetic. I'm, in late 20s. I didn't get type 1 diabetes, late 20s. Anyway, another colleague of mine, also a GP, had a glucometer in his car, and he went and tested it. My blood sugar was off the scale, ruined the wedding for me, and there and then at a wedding I was diagnosed with diabetes, and glucometers have played an important part of my life ever since, not just as a GP but now as a patient. To my shame, the radiologist that diagnoses a GP with diabetes is still grates a little bit, but for me as someone with diabetes and now using a glucometer that is connected to my pump, which tells me my blood sugar every 5 seconds and I can track it through the day, gives me an idea that technology spanning over the last 40, 50 years has really changed, but the principle stays the same. This bit of technology prevents me from getting this, which is, hopefully prevents me from getting this, which is diabetic retinopathy. Makes me go blind at the age of 40, 50, 60, I don't know. But for me, as a patient, there's real value in a glucometer. There's huge amounts of value. As a commissioner, there's real value. I'm prepared to spend over, I think it's 3 or 4, I'm looking at Neil Evans, my colleague here, 3 or 4 million on blood testing equipment and strips because it makes sense, it makes value, it improves outcomes as a commissioner. As a provider, it's really of value to me. It makes my life a lot easier to give a glucometer to my patients and ask them to manage their condition than for me to keep testing their sugars themselves. And of course, ultimately, it achieves better outcomes. It produces, good blood glucose control really does make a huge difference to outcomes, to lifestyle, and to link technology to outcomes is the aim of why we're here today. And I would suggest that a glucometer really hits the sweet spot. I'm going to use the golfing analogy. I don't play golf well myself, but it hits the sweet spot because it's a win-win for everybody. The commissioners, the providers, the patients all see the value, and it's adopted by everybody as a piece of kit which aligns to everyone's objective. But there's so much technology out there that could have the same approach at reducing mortality, reducing morbidity, improving quality of life, that we do not adopt. And that's because it doesn't hit the sweet spot. And it's not the technology's fault, it's the system's fault. I met with this our Grand Master last year, who was going on and on about Skype. On and on about Skype, about how we adopted it. It was a case of saying, Mr. Hunt, we've had the telephone for a century, yet finding a GP to just pick up the phone and speak to, if they're not using the telephone as a means of communication, what makes you think they're going to actually use technology to improve outcomes through Skype? There must be a reason somewhere along the system that Skype isn't being adopted, and there's numerous reasons. I won't go into it now, and it might work in the Outback or in the Hebrides, but in rural Eastern Cheshire, most people can walk to their local GP, and as we found today, Wi-Fi or 3G or 4G is not necessarily something that we can depend upon for Skype. So we talked about the challenges in the system, and you can break it down to very much like this. If the commissioners want to achieve an outcome, and as a CCG, it's all about outcomes for me. It's all about making those differences. It has to do it at the moment the old world way. And that basically means a commissioner, be it Mr. Hunt, be it myself, be it my colleagues in NHS England, developing some sort of specification that applies a value to it and says, achieve this, deliver that service or achieve that target. And it's quite dictatorship about that. It sort of says you must deliver this service. It doesn't pay the hospital or the GP or the whole system to achieve an outcome. It doesn't say, listen, Derby, you've got ridiculous rates of diabetic retinopathy, you've got ridiculous rates of diabetic amputation, you need to reduce this by 10% in 5 years and 20%. It doesn't pay and reward the system for that, which would, if you imagine it did that, just imagine the diabetologists and the nurses and the dietitians and the patients being empowered to think innovatively about how they'd achieve that. No, it sets values, it sets targets, and expects the providers to actually deliver a fairly traditional service. And if you in Newcastle or in Truro, I suspect your diabetes service will be pretty run on a similar sort of service specification. The providers will then deliver that service to the patient, they're paid for delivering the service, not achieving the outcome, and you might get a situation the patient gets the outcome. But are we really likely to see the outcomes that we need in this old world way? And there are success stories. Technology has been adopted by commissioners directly for patients. A recent thing here in East Cheshire is that the commissioners bought a license to Big White Wall, which is an online psychological, emotional support piece of software for people with mental health problems. It's developed for veterans. And it's a great way of demonstrating that you hit the sweet spot there. The patients like it, the commissioners like it, it's cheaper than sending for counsellors, and actually it's got good evidence that it works. But at the same time, we've tried to adopt other technologies, but providers do not necessarily run with it because they see no value in it. At the same time, some providers have really obviously adopted all sorts of technology in our surgeries and in our hospitals. But at the same time, we have some really innovative people at Oakley. I'm pleased to see Dr. Sarah Van An here, who's one of my colleagues from East Cheshire Trust, who has put in some of our local nursing homes a face-to-face monitor, a telemedicine kit between the nursing home, the GP surgery, and the local A&E admissions unit. And you can have a three-way conversation without the patient leaving their bed between a doctor perhaps visiting that patient in that nursing home, the GP, and the hospital. A fantastic idea. We've got the highest nursing home population in the northwest here, and it could revolutionise the way we support people in our care homes. But of course, the hospital doesn't get any payment for that. Actually, the hospital only get paid if that patient ends up in their department because of the tariff system. So if something seriously broke there, there's something, Dr. Sarah Van An is really sort of fighting against the tide here because the system does not reward that sort of innovation. And finally, the tech that's available that patients can procure themselves personally doesn't, again, necessarily get recognised and adopted by the system. So to hit that sweet spot where technology is adopted by the commissioners, the providers, all the patients, and you have that alignment in terms of value and achieving those objectives is a really difficult area in an old world system. So let me talk to you a little bit about what we're doing here in Eastern Cheshire and moving to a new world way of commissioning, a far more, I hope, mature way, a 21st century way of commissioning. And that is not to dictate and micromanage and micro-design how providers should provide care and how patients should be the recipients of those care. In fact, we should be a lot more hands-off, a lot more mature in our relationship with our public and with our providers, to not separate housing authorities from community trusts, from mental health, from secondary care, from primary care, but to look at all these assets that we've got in East Cheshire and to see that if they work together as one, they can achieve the short, medium, long-term outcomes needed for our population by working together. And actually, if we are brave enough as commissioners to stop orchestrating every little bit of the orchestra and saying you have to do that bit, because if you do that bit, you'll work with that bit and you'll work with that bit, because we know people fall between the gaps. But instead, if we're brave enough to say, these are the outcomes we need to achieve as a health economy, health and care economy in the next 5-10 years. These are the standards to which we would like you to work to, and they're defined nationally by NICE and CQC, etc. This is the budget. This is the money we've got. It's not getting any bigger. It's not getting any smaller. That's it. And actually, let's be a little more mature about the relationship we've got. If you manage to deliver that within an envelope, and then let's share the benefits of that. Let's share the risk as well. And we've called this approach Caring Together. And the commissioners, that's not just the CCG, but NHS England and the council and our public health colleagues, can hold the system to account on this framework. Then we want our providers, we need our providers to think of themselves as one. And I talk about providers not being just our GPs and our hospital trusts, and not just our mental health services and our community services, but also social care providers, housing authorities, the community, the voluntary sector, to actually think of themselves as one, as some association, some alliance of individuals who jointly, on behalf of the public, work to achieve those outcomes. And that Caring Together association and alliance, using the most appropriate tech, giving them the freedom to embrace the best risk stratification technology, the best data collection technology, collecting data from across that area, not just the GPs who tend to be the default data collection point, will empower patients and to realise that if they empower patients with technology, then you can have this perfect marriage of empowered patients using technology, empowered providers using technology to achieve the outcomes that go far beyond what we currently achieve. Now, a lot of people in the NHS think that's a complete pipe dream, and even local colleagues say that's never going to work. GPs aren't going to give up this, the hospitals aren't going to give up that autonomy. But I believe that they will, because they'll see that actually working together, if you were an alien from outer space and you saw the disseminated way that our organisations here in East Cheshire work against each other to different incentives with fantastic bits of technology that sit on shelves or not even investigated because they see, well, that will never work. But actually an alien would say, this is the best way of delivering care in Eastern Cheshire, and this is the best way for the purchasers of care, me as a commissioner, can actually do that. So I hope that makes sense to you, because this is where I think technology can really play a part. But what I'm asking you today is to think of the technology that you're here thinking about, representing, and say, why, if it is hitting the sweet spot, why? Why have commissioners, providers, patients adopted this? And how is it delivering an outcome? And how can I demonstrate that? The evidence shows it, but why has the system adopted it? Or probably more importantly, well, I want to know, why has the system not adopted it? Why have I knocked on the doors of 20 CCGs and had meetings with NHS England over the last 5 years, and the technology is still not being adopted? What is it in the system that is preventing this piece of evidence-based technology from actually helping economies like our own and people like our own? And the breakout sessions later, I hope, will extract that information. For me as a patient and for me as a commissioner and as a GP, I really feel I need to understand where the blocks are in the system so that technology can make a difference. And I know that you'll be pushing against an open door with technology if we achieve, and I believe we will, achieve this association of providers working together to one outcomes-based framework where everyone is focused on the outcomes for people and doing that through empowering people, patients and carers to manage their own care where possible. And lastly, I suppose a quote which resonated a little bit with me is that this pump really works. It doesn't let me forget that if I've been sat in surgery all day on the Thursday when I'm on call, basically doing nothing, eating hobnobs, getting stressed about the lines of patients I'm seeing, it doesn't let me forget that. It works. It bleeps because my blood sugar's going up. I'm pumping myself full of insulin. Yet on a Sunday morning when I'm out cycling in the Peak District, it doesn't let me forget that I should really stop giving myself as much insulin because I'm having hypos. And it's a fantastic bit of kit and technology that just works. And for me it works, and for my GP it works, and from my commissioner, with my other hat on, it really does work. I've just reflected on the fact that if the NHS continues to close its doors to technology, it won't move on. If it also keeps closing its eyes to completely new ways of working, completely new ways of contracting, financing, arranging itself, then it will not work. And I believe that East Cheshire is in the right state to start accepting transformational, evolutionary ways of working for our population. And we need the help from outside the NHS to understand what is possible. And so it's not just what technology is possible, what attitudes are possible, what behaviours are possible within the care force and within our population. So thank you so much for coming and helping me understand that today. I look forward to spending some time with you. As I said, I'm in surgery this afternoon, and then I've got sports day, so I'll be wearing my Apple Watch pedometer to see if I reach today's target of, 5,000 steps, otherwise it will start vibrating at me and telling me off. So I'm sorry I can't stay the whole day, but I thank you so much for your time, and I hope you enjoy the rest of the day. Thank you.